My name is Kristen Thelen. I am an optometrist at Emory University in Atlanta, Georgia. I work in our comprehensive department, and about 20% of my patients are emergencies. I do a lot of triage care. We have a pretty large department, of about 30 providers, so I see a wide variety of emergencies. So thank you for being here today. We really appreciate it.
Hi, good morning. I am Farah Gulaid. I also work at Emory Eye Center. I'm here in Atlanta, Georgia. I work specifically in glaucoma care, and I also do hospital and emergency room care at the hospital.
So before we get started, we have a few objectives for this next hour. And overall, we just want this to be a fun overview of things that we are all aware of, but maybe don't see on a daily basis. And it should just be a nice reminder of, kind of emergencies and things that should raise a red flag. One, we will review, how to accurately obtain a symptom assessment and chief complaint. Two, we will review symptoms that are associated with true emergencies. And lastly, we'll go over a few cases that we have seen in clinic personally that we both found interesting.
All right, so I know and understand that this is a global audience, and we're very excited to be here with you all, and that we're all so connected with Zoom. And so we do want to know what your mode of practice or the type of practice that you're in, if you guys could answer that. Our setting is kind of more of a hospital setting, community healthcare clinic setting, and so really interested to see what type of work you all are doing. All right, so it looks like we're among company here, and we're really excited to hear your perspectives in the chat and really just kind of go over our the type of work we're doing on a daily basis.
And please feel free to ask questions throughout the talk. We will do our best to answer. So symptom assessment and contents of a thorough chief complaint. Certainly your standard location, severity, duration, onset, modifying factors, and associated signs and symptoms. In general, I like to remind myself to always use open-ended questions. I try not to ask yes or no questions. I think the more information you can get from a patient, the better. Sometimes that, you kind of shoot yourself in the foot with that method, but it does tend to bring out kind of the never-ending historians. And sometimes you get complaints about things that are totally not eye-related. I'm sure that's happened to all of us, but I think the more information you can get, the better. Oftentimes you can even make a diagnosis before you take a look at the patient if you take a very thorough chief complaint and HPI. Things that prompt patients to call and ask for urgent evaluations. Oftentimes burning is a big one, burning and eye discomfort. Usually it's non-emergent lid diseases like blepharitis or MGD. Occasionally we'll see styes that have developed into preseptal cellulitis. If there's a fever associated with it or double vision, that of course raises a red flag for orbital cellulitis. So those patients obviously get same day appointments, but that doesn't happen very often. So when patients call complaining of burning, we usually try and triage them over the phone, moisture drops, maybe some Tobradex, things like that, warm compresses. On the opposite end of the spectrum, double vision always gives me a little bit of heartburn. There's such a broad etiology for new onset double vision, and some of those etiologies can be vision threatening or even life threatening. So we will move on to a question here before we talk more about double vision. Which of the following symptoms is more alarming for a potentially serious underlying systemic complication? A, monocular double vision, B, binocular double vision, or C, double vision that occurs only when reading for an hour or more.
And I'll just have to say that this is probably my least favorite patient that comes into the clinic. You're going to have to do some neurological workup, and it can often be a scary etiology for both yourself and the patient, of course.
Fantastic. very smart audience here. So, so binocular double vision is definitely more alarming. Sources certainly would include, optic or ocular motor palsy, cranial nerve 6, 3, or 4. Can cause double vision. Causes of those palsies include strokes, viral infections, sometimes just uncontrolled diabetes, which happens to be the #1 risk factor for developing cranial nerve 6 palsy. And that's for adults. Cranial nerve 6 palsy is the most common ocular motor palsy in adults. But for kids, it's actually cranial nerve 4. Again, you really have to take in the patient's overall health and risk factors to help you determine an appropriate workup. If any patient that presents with diplopia from a 6 palsy, even if I suspect a ischemic etiology like uncontrolled diabetes, I'll always order a SED rate and a CRP if they're over 65. It's not common, but it is possible for a 6 palsy to be a presenting symptom of GCA, and that's always something that I'm worried about. So we like to keep that in mind.
All right, so blurry vision here. We hear it, and it's sometimes difficult to sift through and figure out the etiology of blurry vision. When we have patients come in, of course, we check visual acuity, and I'm a stickler for pinhole acuity, so I can factor out any vision-related, of course, cataract or corneal problems. And so, I often sometimes will do a quick refraction just to see if I can get them down to their historical vision, of course. So now we're kind of thinking about non-emergent versus emergent cases. Sometimes our dry eye patients are probably symptomology-wise the least happy. They're going to come in with sharp pains and discomfort, and sometimes urgent consults. And through our call center, they do a good job of really kind of helping these patients with dry eye and not bringing them in for emergent evaluation. When we look at emergent cases, we're thinking retinal detachment, vascular, occlusions, TIA and stroke, angle closure, giant cell arteritis. So we're going to talk more about that. These non-emergent cases, conjunctivitis, these often don't come directly to our clinic. I think our patients go to like urgent cares, or they call us over the phone and we mitigate it through that method. And then if things don't improve over time, we bring them into the clinic and do a full assessment. Yeah, so discharge, of course, non-emergent sources of discharge, dry eye, they're going to get excessive watering as a reflex. Chronic conjunctivitis, allergic conjunctivitis has a similar presentation. When we look at emergent sources, we're thinking like mucopurulent, mucus-like discharge, or contact. Anytime they're saying anything about contact lenses, I think our call center and fellows are really good about bringing those patients in immediately when it's contact lens related. So eye pain, and we talked about the dry eye patient, but let's talk about like corneal abrasions. Those often come because of the severe pain that's connected with abrasions. They often come into our emergency room and then we evaluate them. But these patients are going to have 10 out of 10 pain, but the history is going to push you towards this diagnosis in addition to your examination. We think about eye fatigue and strain. I'm hearing a lot about this. A lot of friends will call me and say, hey, I've been on the computer all day because of Zoom and the way that we're living these days because of COVID. And they're having to stop work or take naps throughout the day. And so they're coming in with some discomfort too. Iritis, of course, injury, but the history will tell you that. Iritis, we'll hear about postoperative patients. They've tapered off of their prednisolone, and then that next day or 2 or 3, they have this kind of painful red eye with light sensitivity. Angle closure will have severe pain sometimes, or I've seen it where it comes in as a dull ache as well, but it's connected with kind of vision decline and kind of redness of the eye as well. All right, so, red eye. Yeah, so there's so many reasons for this. We have dry eye, of course, a subconjunctival hemorrhage, which here looks really scary for patients, but when we see it, we're like, see you later. You know what I mean? And we're really happy about this, unless they have frequent and recurrent subconjunctival hemorrhages, and then we'll order clotting factors, of course. There is conjunctivitis, injury, inflammation, and so a really thorough eye exam will kind of tell you exactly what's going on. You know, Dr. Thelen and I have this principle of, hey, you know, no one's going to fault you for bringing in a patient and looking at them and taking care of them. And so, and figuring it out and telling, hey, it's just some subconjunctival hemorrhage. See if, you know, this is going to improve in 14 days. And so to give them that reassurance, I think they're super appreciative of.
And I think, you know, red eyes are something in our profession that work really well with telehealth clinics.
Mm-hmm.
I think it's very tough for us to have, you know, very thorough or wide scope exams with telehealth, but red eyes are really fantastic for those types of visits. I would say 5 out of 10 telehealth visits that we do for red eyes are subcongenes. And it's always a great experience to, you know, tell someone like, hey, this is nothing. It's all good news. Just leave it alone. It's, you know, not going to give you any trouble.
Oh, I was muted. So here's a question for you guys. Which of the following red eyes also presents with 10 out of 10 pain? We had a great question here. It said, some people complain about throbbing pain in the globe with normal IOP. How do you interpret? You know, if the pressure is normal and my entire exam is normal, I do think most of the time it's dry eye related or just kind of discomfort. And so, you know, we'll recommend using frequent use of artificial tears, a bland ophthalmic ointment for bedtime, and then reassess perhaps through a phone or having them come back in a few weeks. Yeah, you're right, guys. Scleritis is it. These patients are going to come in very uncomfortable. I had a patient during, you know, COVID who came in through the emergency room, and she had a really significant epidemic keratoconjunctivitis that presented with a scleritis. And because her pain was so different or outside of what we would expect for EKC, we did order an MRI, and they saw scleritis. We watched her closely, and she got better over a few weeks. But what we determined was that with our uveitis specialist, that it was EKC, a really bad one at that.
Yeah, and just to touch on that question from the audience, you know, if someone came in with a white and quiet eye, but their only symptom was throbbing pain behind the globe, certainly I would be worried about something like optic neuritis, or perhaps posterior scleritis. So a B scan is usually pretty helpful when trying to differentiate or rule out one of those two conditions. And scleritis, again, is the answer.
Now we have the symptom of the ominous flashes and floaters, right? And often, you know, patients, we have a great support team, but they don't tell the technicians or support team members that they have flashes and floaters, and they'll tell me, and I'm like, I got to dilate you, you know, so that we can just go to the back of the eye and see exactly what's going on. When we think about these types of photopsias and subjective visual disturbances, we look and we're going to see and assess if there's any tearing of the eye, if there's a vitreous hemorrhage, which is less concerning, and we actually just watch for over a period of a month. Of course, trauma the case history would tell you it was trauma related. Migraine, like ocular migraines or even classical migraines that present with aura can have these photopsia presentations. And so really a good clinical exam is going to point you in the direction of what exactly is going on. I have a lot of patients who, you know, they are having these photopsias. I assume it's kind of a forming PVD that's not there yet. And so we'll see them about 3 to 4 weeks later or sooner, depending on their symptomology, to assess for a PVD that forms or a retinal tear in a few weeks.
It's nice when the etiology for the floaters and flashes is very well defined. Like if you see a PVD or a case of nudes, that's always, you know, great and fantastic. But sometimes you don't see any ocular findings to explain something like flashing lights or floaters. So that's kind of when you should start worrying.
I'd also recommend that you dilate both eyes. A lot of patients perceive photopsias in one eye and something's actually going on in the other eye, and they don't often check laterality, but they'll swear it's their right eye or their left eye. I would dilate both eyes.
That's a great point. And laterality is, you know, we know that that is very difficult sometimes for patients to describe. In fact, I think most migraines are bilateral, but I would say half of my patients that have migraines, they only complain of symptoms in one eye. And when you ask, are you sure it's just one eye? Oftentimes they think about it and they say, oh, I'm not really sure. I'll have to pay attention to it later. But most of the time, ocular migraines are bilateral. So some examples of some worrisome complaints. I lost vision in my right eye for a couple minutes, but it came back. That's always alarming. Anytime you have an episode of transient vision loss, whether it's monocular or binocular, that should warrant an immediate workup, same day if possible. I'm experiencing 10 out of 10 eye pain and nausea. Obviously, we would be concerned about an acute angle closure anytime someone complains of nausea and severe eye pain. I slept in my contact lenses and my eyes hurt. This is always a red flag. I always tell patients that's the worst thing you can do with contact lenses is sleep in them. Even though there are lenses that are FDA approved for 30 days of continuous wear, we always encourage our patients to take the lenses out and just avoid any additional risk for keratitis. If anyone ever says they can't open their eye or, again, seeing double, those are red flags that we worry about, and we would want to see the patient right away if they're complaining of something like that. And I always like this little cartoon with the pumpkin. It says, this might sting a little, but your depth perception should improve almost immediately.
All right, so let's get into true ocular emergencies here. This is kind of a hefty bag, but I'll say that we see all of this quite frequently. I definitely would say a few times a month in our triage clinics per provider. We are definitely tuned into a central retinal artery occlusion where you have to rule out a giant cell arteritis or causes for emboli. Unilateral, acute, sudden, painless vision loss is always concerning and requires an immediate workup in the emergency room. You're going to want to order like ESR and then CRP, which is a better indicator and isn't always will not be elevated in cases with patients with inflammatory conditions. So if both of them are elevated, that kind of gets you tuned into giant cell arteritis. When you think of CRAO, central retinal artery occlusion, you see this chalky white fundus. And that's a tougher case to manage because often they come in too late to really do anything about it. But we're trying to assess what's going on. Of course, there's acute angle closure, and we'll talk a little more about that as well, and GCA. A macular on retinal detachment as well is a concerning condition. If the MAC is off, our retinal surgeons will wait a little while, and so with the MAC on, they're going to do surgery immediately. Of course, we discussed the acute third nerve palsy. We want to rule out an aneurysm here. When we look at the ocular motor nerve, the pupillary parasympathetic fibers line the ocular motor nerve. And so if the pupil is involved and the eye's down and out with pupil involvement, then that tells us and lends us to believe that there is an aneurysm. And so we want immediate imaging. Of course, corneal microbial keratitis, usually connected with contact lens, open globe, and we'll have a case there. Endophthalmitis, that's both exogenous or endogenous, chemical injury, and orbital cellulitis I see quite often in the emergency room. We do a CT there, and then they usually are admitted for IV antibiotics bedside.
And I think we received a question about, when should we refer for a MAC on rhegmatogenous retinal detachment? And really, a lot of it depends on where the retinal tear is. Of course, if it's superior and as gravity is doing its thing, I think there's a higher risk for the macula coming off sooner. So I would say within 24 hours, you want to try and get that patient seen by a retinal specialist. I think if the tear is inferior, perhaps you have a little bit more time, but I would still say within 48 hours. And anytime you have a MAC on RD, it's always good to educate the patient and tell them to take it easy. If they are going in the next day, you can tell them to lie towards the tear, wherever the tear is, if it's possible. To do some positional prophylaxis to make sure they don't make it worse while they're waiting for that referral. So case number one, this was a patient that I saw. He was an 84-year-old white male complaining of episodes of vision loss while watching TV, along with some redness. He said it had started about a month ago. He described it as severe. He would lose vision completely for about 5 to 10 minutes. And again, he said just his right eye, no symptoms in the left eye. Additional symptoms, he complained of occasional double vision that had been going on for about 2 years, which he described as mild. So we took a look at him, we dilated both eyes, and the entrance testing showed a slightly reduced acuity in both eyes. Anteriorly, he had some iris neovascularization, 2+ cell with mild anterior uveitis. Posteriorly, he had a vitreous hemorrhage in both eyes. His discs had some neovascularization, and then he had scattered retinal hemes throughout. This individual had a known history of carotid artery disease, so that was probably the most important thing when determining a diagnosis and a plan for this individual. Because of the laterality of it, because it was in both eyes, OIS wasn't necessarily at the top of my differentials. I was thinking something like a bilateral vein occlusion or uncontrolled diabetic eye disease. But with his history of carotid artery disease, I was very worried about some occlusion in his internal carotid. So we actually sent him to the emergency room for a carotid Doppler, where his results showed he was over 90% stenosed on both sides. He had an emergent endarterectomy that same day, which perhaps could have saved his life or his vision. Just as a reminder, any patient that has 50 to 60% occlusion on your internal carotid artery, that is when the risk for stroke goes up, and that's usually the threshold for treating the stenosis. Thankfully, he did well. He had a successful, like I said, endarterectomy, came back to the clinic. We ended up doing some PRP and anti-VEGF injections because he had had some neovascularization, but he did fine and his vision was pretty stable. I think this was a really interesting case that stuck with me because I always associated OIS as a unilateral condition, but in fact, 22% of the time, OIS is bilateral.
So it looks like someone even asked this question just a moment ago, and I said, hold tight, we're almost there. But giant cell arteritis, it's the most common primary vasculitis in adults. We get this in our both emergency room, or we'll get consulted either by the rheumatology team or neurology team at our hospital. And they really want us to assess the optic nerve. This condition is marked by a granulomatous inflammation of medium to large size blood vessels, and is typically seen in older individuals, anywhere between 50 and 70, but definitely in the older range, and in women more specifically. Their presenting symptoms are often vision loss. They'll have a temporal headache, and sometimes you'll see bulging of like a temporal artery here. I don't see that as often, but that's classic, kind of one of the classic symptoms. They'll have scalp tenderness, and I'll ask them, hey, did you comb your hair? And did you notice some discomfort there? They'll have fatigue, jaw claudication, especially when chewing, diplopia on some occasion. I don't see that as often. Shoulder or neck pain, and then unintended weight loss. And they're like, yeah, I have been losing weight and I'm not sure. Since this condition can progress rapidly and can involve the fellow eye within a few days, this is considered definitely an ophthalmic emergency. And if suspected, someone asked this great question earlier, that we definitely rule out, of course, infectious etiology, but that we start IV steroids as soon as possible. And in some cases we'll do a temporal artery biopsy, but often these lesions have skip lesions. And so they'll take a 2 to 3 millimeter biopsy here, but then sometimes they don't see the transluminal inflammation there. And but empirically they'll continue the steroids and assess for improvement in vision or overall condition. And I'm seeing here in my notes that skip lesions are seen often in 8.5 to 28% of patients. So, you know, we do empirically treat these patients here. Yeah.
And I think it's important to remember too that the most commonly associated systemic condition with giant cell arteritis is polymyalgia rheumatica.
Mm-hmm.
Those patients are at a higher risk for developing GCA. I think that's an often overlooked aspect of this disease. Mm-hmm. So it's a nice reminder, you know, to keep a lookout for that in patients' medical history.
Yeah, and someone asked about ethnicities. We commonly see it in Caucasian patients, but I've seen it in a wide range of patients coming in. I think mostly I'm tuned, and I've seen it in men, of course, probably anecdotally about 50% of patients, but in literature, it's definitely people who are older and in women.
Yeah, that's a great question.
And also, I will say that we often don't see the optic nerve swelling, but the absence of optic nerve edema or that chalky white edema does not rule out GCA, and we tell them that every single time.
Yeah, absolutely.
So are the episodes, oh, this is you, Kristen, sorry.
Oh, you're good. So this is more in reference to the OIS case, but were the episodes of vision loss and this patient's visible eye redness associated? Okay, so interesting. 40% of you guys said yes, 21% no, 38% maybe. So the answer is yes. The severe carotid artery occlusive disease leads to ocular hypoperfusion. And so that's what starts this really ischemic cascade where he eventually developed the anterior neovascularization of the iris, leading to cell and inflammation and redness and ciliary body injection. So yes, definitely connected. So to summarize that initial case and kind of the takeaway points, any patient complaining of transient vision loss, whether it's monocular, binocular, whether they're 15 years old or 55 years old, they really need an urgent evaluation to figure out if it's an ocular, a neurological, or a vascular etiology. Number two, vascular sources of TVL are usually associated in older 65 plus age group. So certainly consider migranous or ocular sources in younger populations. And lastly, an increased suspicion for vascular etiology when the eye exam is unremarkable. So that's always a difficult situation when your patient has experienced an episode of vision loss and you look in the eyes, everything looks great and you don't have a very well-defined reason. But ultimately you have to take a deep dive into their overall systemic health and assess their risk for a more alarming concern that could affect their general health and really assess their risk for a stroke. And that takes some finesse, I think, to educate patients with saying, hey, your eyes look fantastic, but I think you need to go to the emergency room for a stroke workup. But truly, we should treat those cases with seriousness and slow down with those patients and really take a minute to assess their risk for something serious.
All right, so this was a case that came in through our emergency room. She was a 41-year-old woman who reported playing with her neighbor's dog on Friday night and waking up Saturday morning with a blurry, painful left eye. And this is where my ears perked up here. She removed her contact lens immediately, which meant she slept in them, but continued to have discomfort and irritation. And I really don't fault patients for this. I was a contact lens abuser as a child or as a younger person. I just, you want to say education helps, but sometimes to do better, you have to know better, and knowing by example sometimes. And so I've had my fair share of little ulcers where I'm a very good contact lens wearer at this point. So this was in her left eye. She had significant pain and it had been going on for a few days. She thinks that maybe the dog maybe licked her or something. And she was using and treating herself with artificial tears. And she was using tap water and sleeping in her contact lenses. So in her left eye, she had hand motion vision, a diffuse injection, and then she had a very large, almost 4 millimeter round central corneal infiltrate, but no hypopyon. And I looked, and it was difficult to assess for cell, but I assumed that she likely had it considering the significant pain and the size of the lesion. So in this case, we wanted to get broad, because this is vision threatening, we wanted to use fortified antibiotics. So I called down to our compounding pharmacy, who then formulated vancomycin, which provides very a broad spectrum coverage, and then tobramycin, which is more narrow, but really is effective for gram-negative bacteria like Pseudomonas, which is often contact lens related and connected to water sources. We'll also add maybe a fortified if fortified antibiotics are not available, and this happens while the patient's waiting, I'll give them a loading dose of a fluoroquinolone 4th generation. I like Vigamox, that's readily available in our clinic, thankfully. And so I'll give her, what I did was gave her about 2 drops of that. You'll often want to give them a cycloplegic agent. You won't give them steroids, right? Because we don't know exactly what the causative agent is. In this clinic at the time, I just newly started and didn't recognize that culture plates weren't there. So, because of the lack of access in this case, we did not culture the patient. But that is like the standard of care, but sometimes you just don't have, everything readily available for you. She actually did get better with this treatment and saw our corneal specialist with the fortified antibiotics here. But I did also add a cycloplegic agent, which also prevents posterior synechiae formation and also helps with discomfort and pain. Is a bandaged contact lens an appropriate treatment for a contact lens related corneal ulcer? Yeah, so yes, you do not want to put the causative agent. What caused her problem is she was immune compromised due to her long-term contact lens wear and overwear of her contact lenses. So in this case, that's not what she'd want to do. But we often use bandaged contact lenses for corneal abrasions. Those patients love me. They want to give me flowers and money that I can't accept. When they have a nick on the corneal without an infiltrate, you look for that, and then you put a bandaged contact lens and see them in a few days, and they're all a lot better and a lot happier with you. So some clinical pearls here. Pseudomonas, as you all know, is a gram-negative bacteria that lives in water and damp environments. So if that contact lens falls into the sink, don't touch it. I often tell people throw it away. And it's a leading cause of contact lens related infections. You want to use something with great gram-negative coverage like tobramycin. Kristen, you'll use a fluoroquinolone sometimes and cover it with tobramycin. Did you say that earlier?
Yeah, absolutely. I always like to have good gram-negative coverage anytime I'm suspicious of Pseudomonas or anytime there's a well-defined contact lens related ulcer.
Yeah, and you want to inform your patients about, again, patients do better when they know better. And so you want to inform patients not to rinse their lenses with tap water. And this is something that I used to do when I was a teenager, but to save money and my parents were, purchasing the contact lens stuff, but to save money and to save the solution, I would just top off the solution. So I take the dirty solution and put some new solution on top. And that just created a reservoir of bacteria that caused the infections that I used to get.
And I'm sure we've all heard this, but I've had patients that tell me they put their RGP under their tongue, which is just so gross. I can't imagine that, but that's just a great recipe for, a major problem. Okay, so this next case, this was a 55-year-old male who was complaining of a watery eye for a couple of months. He had a very significant, very lengthy ocular history which was most notable for a failed RD repair in his left eye, which left him with count fingers vision. He had also had a PK in his left eye, and in his right eye, which was his good eye, a subluxated IOL with vitreous prolapse. Medical history is significant for arthritis, asthma, and hypertension. When I took a look at him, his VA and his visual acuity in the right eye was around 20/40, but it did fluctuate a lot with blinking, and because of that watery discharge, his pressure was a little bit lower on the right side, but 20, and his left eye was 23. So I actually have a video here. If you guys will bear with me for just a second, I can pull it up on this other slide. Good. So hopefully everybody can see this, but so again, this is a monocular patient who comes in on a Friday at 5 o'clock. And when I pulled his lid up, you can kind of see some aqueous coming out there. So this made my stomach turn a little bit. It was interesting that he had had this for several months. And he kind of just waited it out. I'm not sure that he really knew. I don't think he knew what the problem was, but he definitely had an open wound there. And we will go back to our presentation here. So for temporary management of an individual with a wound leak like his, we put a bandage contact lens with some antibiotic coverage. I think we use Cipro 4 times a day. We also started him on Timolol twice a day in this eye to reduce aqueous production. Long-term management, it was a very complex case for him. He had multiple amniotic membranes. He had ocular surface reconstruction. He had 5 FU injections. It was a very complex and lengthy kind of resolution for him. I think eventually he did get to a point where that wound was not leaking, but it took a lot of time. And I think it was, we watched him closely because he only had one good eye. Concerns with open globes or wound leaks. Long-term, we worry about hypotony, choroidal effusion, even endophthalmitis, retinal detachment. So he was sort of a special patient that we paid very close attention to. Thankfully, he did fine, but yeah, it was an interesting one.
Kind of touch base here in the glaucoma department. I think once a week or twice a week, we'll get a Bleb Leak. So patients who've had prior trabeculectomy in the eye, they're actually at lifetime risk for a leak of the bleb. These blebs often, if there's no infiltrate there, then we'll just give them aggressive lubrication. These thin blebs often with rubbing or just dryness can just thin out further and cause these leaks. And so you'll see this side L positive here. And I just had one the other day that did really well when we gave them every hour artificial tears, preservative-free artificial tears, of course. We cover them with an antibiotic. And I think I gave him ofloxacin and then, of course, ointment at bedtime. We will also use a bandage contact lens if the leak is a little more significant. And someone asked a great question about when to use therapeutic lenses. We touched on corneal abrasion, but we can also use a large diameter lens to plug a bleb leak. And so you also want to, of course, make sure that the patient doesn't have a very low pressure. And if they do, I often just dilate the patient to make sure that the choroid, there aren't kissing choroids, if you will, or the choroids aren't the eye isn't folding in on itself because of the hypotony. This is my place, right? All right, so this is a case that happened again during the shutdown in our clinic because of COVID. And so there was limited resources and limited help at the clinic as we were all manning different clinics, but there weren't many providers around. And so this was a 69-year-old African-American male who was actually previously monitored in our clinic as a borderline glaucoma suspect and, looked quite normal otherwise on no treatment, and presented to the clinic with sudden vision loss upon awakening. of his right eye, which was associated with kind of a mild dull ache, but not anything significant. And then red eye also. He was hand motioned, and that's always kind of scary. And he didn't, even his symptomology didn't seem like it was a hand motion eye. And then when you check it, you're like, oh, this is a little more significant, sir. And then he had a 1+ relative afferent pupillary defect. 1+ can be maybe sometimes a little tougher to see. You want to look for initial constriction, and he definitely didn't have that there. His pressure was 64 in his in that right eye. And then he had, of course, corneal edema, which is classic. He had injection. He had peripheral iris corneal touch, and peripherally, but no neovascularization. So this is my chart. I am kind of the queen, if you will, of pertinent negatives. I like to write what I'm not seeing for myself, and also if there's someone else carrying on the chart so they know, hey, I looked for this, it wasn't there, this is likely the etiology. So of course we want to think, does the patient have an AC reaction? If a patient has an AC reaction, you're going to think, oh, high pressure with an AC reaction, probably herpetic etiology. He did not have that, and I wrote no cellular flare there. You want to see if they have peripheral or posterior synechiae. Is neovascularization, is that present? And sometimes what neovascularization does is zip up the angle and causes a pressure increase. And those patients need to go to retina for intravitreal Avastin, and not an LPI immediately for that hot eye. And sometimes they'll do both at the same day, but they need both providers there. Is the condition unilateral or bilateral? Bilateral, I've had a patient come in, and what she had was uveal fusion syndrome due to her recent use of a new medication. And also, is there an infiltrate or an ulcer present? So I just, as you can see in my chart here, I just write a lot and make sure that I'm, looking for other things, despite me knowing and narrowing in on acute angle closure glaucoma. We also did gonioscopy, and he was occludable. He had no angles or no structures visible. So what tests, and I kind of gave you the answer, I'm sorry. What tests would you do next? Oh, here we go. So gonioscopy, definitely. And if Kristen, if we could advance the slide so you can see the answer. Yes. So that day, of course, we did gonioscopy. He was occludable, but we also did B-scan just to make sure there was no mass effect. I don't know if this is something you necessarily have to do, but I had the B-scan there in that room, and I said, hey, what the heck? Let's just make sure before I send him over to the main campus to see a glaucoma surgeon to get a procedure. Let's make sure that there is no mass effect in the back of the eye that could be causing kind of this rolling forward and causing occlusion of the eye. So in this case here, the patient actually did really well. I gave him a series of meds here. If you look all the way at the bottom, I gave him 2 tablets of acetazolamide Diamox, aproclonidine, and Timolol. I basically gave him the kitchen sink of aqueous suppressants. We didn't have dorzolamide, or I would have put that in his eye as well. And then his pressure improved. I didn't wait around though. I kind of dumped him with all of that. I called the glaucoma surgeon, and then him and his wife went over to the clinic that's about 15 to 20 minutes away, and he got his pressure had improved to around 50s. And since the eye's not as hot as we call it, they did an LPI. They ended up saying that he had a phacomorphic component. So an advancement of his cataract presentation caused, and if you see that photo picture on the right, caused a bulging forward of the lens that closes off the filtering system of the eye, the angle. And so they ended up doing cataract surgery. He did really well. He was hand motion, but he went back to 20/20 vision. All right, guys. So we went through that pretty quickly. You guys have a lot of questions here, and we hope to answer them live. So someone asked, does GCA usually occur in older patients only, or is there a chance for younger females to be having this? I think 50 is young. Those patients are coming in pretty quick, or moving really quickly and kind of with it. 70 is young to me. But yes, it's typically in older patients, typically women, typically Caucasian, but that's the exact demographic, but it's shown up quite frequently. I don't see GCA in younger patients, like a 40-year-old, a 30-year-old. I don't usually see that. But I saw someone here, Laura Cole, said her husband had GCA and he was 60 years old. So yeah, it happens, but that is the age demographic that you can see it in. That's interesting for sure. And I'll take, Kristen, are you able to see the questions too?
Yeah, I can.
I was going to answer the quick one about the role of mannitol in acute angle closure. So we often, I don't see that we use mannitol often. In our guidelines, standard of care here in the States, if the pressure is greater than 50 and isn't coming down on topical therapy, then we would do IV mannitol. And that's just to suck the fluid out of the eye. It's a transient treatment, but it will work really nicely to kind of figure out, especially in a patient, a hot eye that's really uncomfortable and you can't even do a good examination, IV mannitol would be a great option.
Yeah, there's another question too. Gonioscopy is contraindicated in inflamed red eyes with acute angle closure and pain. I think that's when, of course, if you suspect angle closure, you have to do gonio. So there's really no way around that. But when gonio is contraindicated, that's usually with corneal findings, right?
Yeah, I agree. You can do gonioscopy on a patient with acute angle closure, and it's uncomfortable there. I don't see why it would be contraindicated. And I'm sorry if I'm getting that incorrect, but yeah, we often do it. The thing is that the eye usually has corneal edema, so you can't even see into the angle. And so you're really using Van Herrick to assess for the IK touch or just appositional kind of examination there.
There was also a question about acanthamoeba and what the treatment is for acanthamoeba keratitis, and that is PHNB and chlorhexidine every hour. Acanthamoeba is a scary one. I think that's where the pain and patient discomfort usually doesn't line up with the presentation. Usually what you see, it looks mild to moderate, but the patient's complaining of severe pain and discomfort. So that's usually what puts you in suspicion for acanthamoeba.
I see a great question here that's really pertinent with the times. Have you seen conjunctivitis in COVID patients? How do you manage them? We have. What was interesting the other day, one of the hospital medicine doctors called us for consult for a red eye. And the patient was COVID positive. To minimize exposure, we actually did a telehealth visit with the provider. He was all suited in his PPE. And of course, they didn't want us to come up there if it was unnecessary. The conjunctivitis is quite mild. It's not vision threatening. We recommended artificial tears, but no, we're not seeing it as frequently, but it has been presented in literature, and I've seen one patient with it.
I like this question from Paul Sheffield. If someone phones in with a penetrating injury, should they be advised to pad the uninjured eye to stop eye movements before coming to the emergency room? I think that would be nice if you could do that, but I'm not sure how they would function to get to the emergency room if they had both eyes, if the good eye was covered and the injured eye had, reduced vision. So I guess maybe it depends on how well they can see with their good eye covered.
Here's a great question by Mukti. The pressure is 70, but no significant corneal edema. Why? Because the condition is chronic. They've been dealing with it. They probably have horrible nerves, appearing optic nerves. I've had a patient come in 60, thought it was a great sunny day outside. I'm like, you're going to be here a little while. We have to bring down your pressure in clinic. And it took about an hour to 2 hours, but you have to prove that the pressure is coming down. I typically give patients, I used to, when I got out of my training, I used to be a stickler, and I'm like, if the pressure isn't below 30, they have to stay here. And so now what I do is, I'm not as a stickler about that. I like to see improvement over a period of time. And so if within the hour I can get them from 50 to 40 or to 30, then I know that the eye's responding. And then we give them just Diamox in clinic in a baggie and then see them the next day. And they usually come back with pressures that are significantly lower and improved.
Cool. I like this question, how to differentiate between early adenoviral conjunctivitis and allergic conjunctivitis. This is a really good question. Sometimes it's challenging. I think laterality, usually adenoviral will start in one eye and spread to the other. Of course, swollen lymph nodes, you can palpate for a preauricular node. If they have a swollen node, that's a hallmark indication of an adenoviral infection. Itchiness can present with both, so that's not always very helpful. And then recent cold or flu-like symptoms, most of the time, I actually think it's 70% of the time, viral conjunctivitis are preceded by cold and flu-like symptoms.
Yeah. I see a great question here. Oh, did I miss it? Oh, someone said and of course I love the glaucoma questions because that's where I'm at most of the time. So we can definitely get off of that track if you guys would like. But here's a acute, they get a lot of acute angle closure here. And they said that because of COVID and difficulty transportation, the condition's refractory. Do you recommend oral and topical meds? I would definitely recommend at least topical meds. And then likely what's going on is that this is phacomorphic. So they likely need cataract surgery and phacomorphic from pupillary block. So if that's possible to do cataract surgery for these patients and assess for, and of course, give them expectations around, hey, we don't know if we can improve your vision, but it's worth a try. Getting that lens out to just take that iris back, and so that the cornea and iris aren't appositional and preventing the fluid from getting out.
Here's another good question. I was hoping you would talk on uveitis. Which is better to use as prophylactic to synechiae, atropine or Madrazosil? Hands down, atropine.
Mm-hmm.
There's more symptoms associated with atropine, so sometimes you have to ask your patients and kind of gauge what they're willing to tolerate. We also have a hard time getting atropine. I think there have been some recalls and we've had to send it to compounding pharmacies and there are some delays there. So sometimes just because Madrazosil is more accessible, we'll use that, but definitely atropine is more effective at stabilizing that blood aqueous barrier, no doubt.
Yeah, Fauzi Muhammad said that Gatti and moxifloxacin are the slice at third generation, and they're actually fourth generation. So thanks for that. We definitely use moxifloxacin and gatifloxacin quite frequently as fourth generation. So sorry for that. And he said that they can be used hourly for bacterial ulcers. And yes, we do increase the amount of frequency for the medication. So great. And someone also said that, hey, it's kind of difficult to get a compounding pharmacy and they're quite expensive to get fortified antibiotics. So these fluoroquinolones are a lot easier to access. And yes, we would recommend hourly, if every half hour use of these meds.
Right. Here's one from Jenny Ang. What causes a low IOP? I understand pressure below 23 is ideal. Does low pressure below 6 warrant a concern? Low IOP can sometimes be caused by an overfunctioning bleb if you have a leak. Also uveitis, if that ciliary body is inflamed, there's going to be less aqueous production. So it really just depends on the presentation of the patient. I don't lose any sleep over a patient that has a pressure of 6 or below as long as everything looks good. In the case that we had earlier with the wound leak, the pressure in the leaking eye was 20. And, I was more worried about him than I would be about a uveitic patient that has a pressure of 6.
Yeah, so our glaucoma surgeon will say, hey, you want a pressure of 6, then you want a pressure of 40, So low pressures are typically easier to manage, of course. You want to make sure that there's no hypotony, no choroidals present. I had this week a case of ocular syphilis that, of course, we presume that's neurosyphilis until we get cerebral spinal studies, but he had very low pressures and he had this granulomatous uveitis and his pressures were like 8 and 9 in each eye, which you wouldn't expect, but likely because of the low grade inflammation in the eye.
This is a really good question. Would you recommend a temporary BCL in a patient who might have a perforated ulcer due to a contact lens abuse? That's interesting. I would say yes, because I think you need an immediate fix for the perforation, because that can spiral into endophthalmitis. So I think that's probably the highest concern. And yeah, I think it would be temporary, a very temporary fix, and you would
Yeah.
keep them on good antibiotic coverage. But what do you think? What's your opinion?
I have, of course, as optometrists, we wouldn't do this in the States, but I've seen corneal surgeons use glue, just glue it over using a contact lens.
Yeah.
Yeah. And then they'll take them to the OR and literally put a patch over the eye.
Yeah. I think if you're in a private setting where, you don't have, access to the glue or to a surgeon who would glue it for you, I definitely think it would be okay to put a BCL on there and then, tell them, hey, drive down the street, go see this corneal specialist. I think that would be smart. I would probably do that.
Let's see here.
Do
you recommend paracentesis in acute glaucoma? I think you have to figure out what's going on with what's the causative etiology of acute glaucoma. If it's due to narrow angles, I don't, that's something maybe a glaucoma surgeon would consider. This is kind of, since I don't do paracentesis, I don't know if that's something that I can speak on here, but that's a great question. I see something about, someone said orbital cellulitis. We see this often. So those patients, of course, they're going to get a CT. Someone asked, hey, how do you assess for a thrombosis versus orbital cellulitis? And that's imaging. The imaging is going to kind of tell you what the causative or the etiology behind this. And then you give them IV antibiotics and assess for improvement there. And they usually are hospitalized for a few days until we assess for improvement.
Yep. Liza asked, if a patient is seeing flashes and floaters, can it be normal, or is it a sign of any vitreous or retina disease? I would say more often than not, it's normal age-related changes, like posterior vitreous detachment. That's like, I would say 9 times out of 10, my patients, that's what they're diagnosed with whenever they come in complaining of sudden onset flashes or floaters. It's unusual for it to be something not age-related, I think.
Yeah, I saw a great question about topiramate causing high pressure. That patient that presented, as I spoke about earlier in our presentation, about bilateral high eye pressure and what appeared like acute angle closure glaucoma, she was on topiramate. And so I think we gave her acetazolamide and topical medications, but then, and just took her off of her topiramate with you talking to her neurologist and PCP, but she actually didn't get PIs for some reason. She did really well with topical and oral medications.
Do you see any other questions?
Yeah, we're here at our last minute. You guys did these are all awesome questions.
Yeah.
I wish we could answer them all.
I think our email address is posted somewhere. So if y'all have any questions, please feel free to reach out to us. My email address is kthelen, that's THELEN, at emory.edu. So I would love to hear from any of you guys.
Yeah, and I am Gulaid at emory.edu or at emory.edu.
Thank you all so much for listening. This is really such a privilege and an honor for us. We really appreciate all of your participation and feedback. Thank you.
All right, have a great day.